from Indonesia, Italy, Bangladesh, and I presume other countries as well. We're so happy to co-host this with APAO. This is usually a small group of family members of the ROP Society, of the Indian ROP Society, but today we're very happy to involve others as well. Let's begin with the agenda. I think I invite our president, Dr. Rajvardhan Azad, to talk about, to address the gathering with his talk, and also to tell us the agenda as we go forward.
Very good morning to all of you, and I want to welcome a very distinguished guest with us, and he's also the Secretary General of World ROP Council, and I think you all know about him, and his name is Domenico Lepore from Italy. He has done a lot of work on retinopathy of prematurity, and another good news is because of Domenico only, is that the World ROP meeting will be held in Florence in December, in the first week of December. I think 2nd, 3rd, 4th December, if I'm correct. 4th, 5th. So 4th, 5th December, this will be in Florence with the Florence Retina meeting, all you must be knowing. So this is a very good news, and all because of him, and all because of persuasion from Anand. Anand was already on the job. I put him there. I said, you get it done. So we have got it done, and it's a very good and wonderful news for us. And then I welcome Rita is here. Rita is our, one of our very strong member of retinopathy of prematurity group, and we welcome her too. And someone from Bangladesh, you said, who is there? Tariq. So Tariq is not here, but he is in the meeting. He is in the meeting, yes. So we welcome all these people, and oh, I have a talk. I thought that I just have to speak. No, this is not here, This talk is not here. This is in APRIA meeting. This is not here, This is not talk. I'm not going to talk here. Anyway, so a couple of things I want to tell all of you. And first thing is what we have done so far. And the first is about the newsletter. And the newsletter, I think Shilpi is here. No, Shilpi is here. So Shilpi is, has already prepared. You have already got the ready with the newsletter, huh? Yeah, she's already got the newsletter ready, and basically the newsletter will cover all the activities of Indian ROP Society, where the members, what is the activity done by members, any honors they have got during this period, and other activities like, holding some awareness workshops, or any instruction courses, or any, publication that we are having. So all these things, and soon she will come, but it will come. And then we are also devising a training and certification. Domenico, we are devising Indian ROP Society. First thing is the newsletter. So we are publishing newsletter. Please publish this in the newsletter about Domenico also, and also about the World ROP meeting together with the Florence Retina meeting. Put the dates there, so and have a wider circulation so that majority of the people know about it. And the second thing is we are also devising a training and certification for the, people who are undergoing training for ROP screening and ROP management. And in fact, Anand is on the job, and most likely we'll have an app, and through the app you can do the certification and also the the training of the young ophthalmologists who want to get trained. We are already doing this collaborative study. Anil is not here. Anil Gangwe, he has done a lot of these studies on anti-VEGF injections, reactivation time. These are all not done in the world literature, for your information. And a big data. For any study, you need a large cohort of patients. You also need a long follow-up. And you also need a very robust methodology. So all these three we have incorporated in the multi-centric study which we have done. 2-3 study, one I think published in Retina. The other one is also published in Indian Journal of Ophthalmology. And we are having for few more publications. And then about the directory of IROP members. So you already have, is ready with you? July. So we'll have a directory of the ROP members of Indian ROP Society. And I'll request Domenico also to have a global kind of resource directory. I can understand that you can't get, the entire world, but at least the major centers, we all know about it. Where is the center located, and who are the people who are there, working there, and what kind of services are available. Only this thing. That's not more than this. Only 3 things. Can you give him a mic? Give, or you can.
The idea is to use the Florence occasion to set a new World ROP Society or Council, if you want. And this will be the occasion to start a committee and realize and give the birth of the society, which means go to the notary and set everything that is needed to then have more structured situation. This is just because he pushed me in doing that, and of course that we are a small family, but we are very strong. We are very united, and I think that in the world there are a lot of people that needs to have reference. In particularly, I'm thinking about South America, Africa, and they need our help, and we need their experience and their expertise. So I think that Florence will be the good occasion, and of course Professor Azad will be our leader. Thank you.
Thank you, Domenico. And we will also look into the possibility of having a task force. Subhadra knows, and Parijat also knows. Few of us were earlier, there was a task force on retinopathy of prematurity. Unfortunately, between last 4-5 years, it is not active, or maybe we need to draw the attention of the the policy makers in the Ministry of Health. So maybe if you are in Delhi, or maybe I'll take Radhika also now Dr. Radhika, who is chief of RP Center. She is the advisor in blindness program to the government of India. So we'll take her also, and we'll go and ask the government to make the task force. So if once we have the task force, definitely it will get going faster than what it is going now. So with this, I conclude here and give the mic to Anand.
Thank you, sir, for setting the agenda. Before we continue, I'd like to invite Dr. Domenico Lepori on the stage, please. Today you are our very special guest, and I'll be having the honor of introducing you before you give the Michael Treacy oration. Also invite Dr. Pramod Bende and Dr. Subhadra Jalali on the stage, please. Okay, so I think sir has set the agenda. It's the newsletter, it's the training and certification, and it's working with government, and that's exactly the 3 talks that we have. My talk, Anand Vinekar. I will just, you need to look back to go forward, as they say. So I'm just going to talk about what we've done so far. It's something that we are happy about, but Anand Vinekar. Folder pe. Right. So what I'm going to talk about is what we've been doing in the past few years. We are almost going to be 10 years now, next year. And we have a lot more agenda to do. And I think reconstituting the national task force is important because, as Dr. Parijat showed yesterday, he still sees about 15 to 20 new cases of stage 5 every week. This means that we have fairly failed as a society to make this a preventable blindness. Two important things here. The person who took over my talk. The person who took over the presidency yesterday specifically said that his agenda. Please laga dijiye talk ko. He's focusing on pediatric blindness. So Dr. Partha is very specifically spoken about that. And second, just a few days later with the WHO Day coming up, 7th, this year's theme is maternal and child and intact survival. So I think we are rightly poised to talk about ROP and preventing blindness. So we started this society almost 10 years ago in 2016 with the idea of bridging barriers and breaking boundaries for ROP care. And this our website talks about all of this. It was 22nd July, so that third week of July is what we celebrate as our founder week. It has now been registered as a society in the Karnataka. That's where we have the office. And these were the founder members, as you can see, and we've grown from 7 members to mentors to about now 248. We have an annual meeting, we have satellite meetings, and we have zonal meetings. So all of you all are aware that in 2016, the first meeting was in Bangalore, followed by Pune, Raipur, Chandigarh. Then, of course, COVID saw us not having these meetings for a couple of years, and then we combined it with the World ROP in 2022. In 2023, it was in Surat, and in 2024 in Chennai. And this year, coming in July this year, will be in the pink city of Jaipur. Zonal meetings started with Sir's leadership, and the idea was to engage with the government. So everywhere we went, we talked with the government, medical colleges, especially government medical colleges. It started with Lady Harding in Jan 2023. Then in April the same year, we did a very, very successful meeting in Calcutta with more than 300 government functionaries coming. Then we combined it with the annual meeting in Chennai with Shankar Netralia taking the lead. And then this year, in February, we did it in the central zone of Nagpur. We have since been engaging with neonatologists and neonatal nurses as well. The idea was to create a training where they will use the camera and to familiarize our doctors who are medically trained to also learn how to do lasers and injections. The society has 2 orations, the Michael Treacy oration. Today the recipient is Professor Domenico. And the Rajvardhan Azad oration, which is given to an international expert. From this year, we've decided to make the alternate year of an international speaker and a national speaker for the Michael Treacy oration. These were the oration awardees from 2017 to currently, as you can see the international awardee. And the Rajvardhan Azad oration given to an international speaker. Dr. Vici is here in the audience, Dr. Zhao, Michael Shapiro in Dubai, Dr. Deepak Nag from Bangladesh. Last year in Chennai, Dr. Kusaka from Japan, and we are yet to decide our speaker in July this year. We have come up with publications. Initially was just to set the agenda of what we want to do as a society, but very soon we decided to do collaborative studies, and I think this has been our strength. This study that Sir was talking about has more than 10,000 eyes, and this is the largest series in the world, and this is what our membership can achieve. If we all work together, we'll be able to produce data that the rest of the world has to look at. Dr. Shilpi has been, doing the newsletter very well, and she's bringing it out on time, and she manages to collate a lot of the data, and she has this editorial board that works with her. We also have an ROP ambassador program led by Dr. Karubi, which basically engages with media. We are still trying to get a brand ambassador. We were very close to getting a film star. We are still looking for that because I think we saw the success of the polio program with Amitabh Bachchan lending his voice. So I think we want to reach there in ROP as well, but this is work in progress. And we have just, as yesterday's inauguration, we released, at least in principle, but the actual print will come few more months later. All of y'all listed here have contributed to it. This is going to be a wonderful AIOS guidelines for ROP, and this is probably the first ROP guideline that's coming out from the society. We are now about 245 members. 2 weeks ago, we are GST registered. We pay taxes until we get an NGO status, which we hope to get this year, if not next financial year, because we just recently got a Darpan ID, which is basically what the government of India expects you to have if you are an NGO, and we are expecting an ATG exemption in the coming financial year. Once we get an ATG exemption, then we will aim for an FCRA clearance so that we can get donations from internationally. Our steps ahead for the next 2 years is training younger colleagues. Sir spoke about the certification, and Dr. Shweta, a friend and colleague, will give you more details on that. The IROP fellowship, this is still something we are working on, where a single young ophthalmologist will be transiting through all the big centers who are a part of the mentors, and will learn a lot about pediatric retina and ROP. Multicentric studies, I think we've shown with example the anti-VEGF, and there's so much more we can do. And Indian leadership in the APRIA Council and the World Council, we know that we have created the World ROP Council, and Dr. Rajvardhan Azad sir is the president of that as well, and you can see the council members. I also welcome Dr. Eli here from Nepal, who is part of the council, and this is something, this is the council that will be hosting the World ROP Council, and Dr. Azad sir's leadership also led to another association very recently in November last year called the APRIA, Asia Pacific Pediatric Retina Association, and the next meeting we're very happy to announce will be in India, and we're going to be hosting it in the region of Patna. So welcoming you all to the 9th annual IROP meeting in Jaipur. In this week or the next, we'll put up the website for you to put up your abstracts. And this year, we're going to have the younger people present, and the mentors just going to be more panelists and to discuss rather than the other way around. So this is what we are continuously working for: collaboration, training, research, education, and awareness. Thank you very much. I'd like to invite now Dr. Shilpi Shah to give us a brief on where the newsletter is, and then after that we'll have the oration. While she's putting up her slides, we are creating some posters. This is actually what the KidROP program did for Government of Karnataka on request. So you see the KidROP logo, but I think once we get it ratified by the council, we'll probably have a uniform set of posters. This is one that is basically meant for the NICU, giving you the 1, 2, 3, 4 rule, and this one a little more generic for ROP: whom to screen, when to screen, how often to screen, what kind of treatments are available. The flower is taken from the symbol of the RBSK. ROP, when it was created in 2016, 2017, the model was a flower, and in the center was the child department. But right now we're putting the baby in the center, and each petal is a level of care. We have also created counseling aids. Again, this was made for Government of Karnataka, and we will hope to put the IROP logo on this soon. And this is, basic pictures on these two posters, of course, but then also what you need to take to an NICU for ROP screening. How do you dilute drops? What does a normal retina look like? Because you can use this as a counseling aid to the parents or even the nurse. Or what are the different stages? And then aggressive ROP, the plus score, laser treatment, what you need to carry as a checklist to the ICU. Again, the similar thing for anti-VEGF. Pictures of what it looks like, regress successfully after laser. Again, the same thing with anti-VEGF. And then finally, some notes on rehabilitation, just in case, stage 5, not to lose hope. So these are some of the things that we will make available. We are calling this the ROP toolkit. It will be available on the website. You will be able to order it, and it will get couriered to you. We'll have a counseling aid, few posters, and if you wish, we can also send you the 32-gauge needle, which we are currently importing, but we hope to make it in India as well, and some speculum and depressors, and a lot of the consent forms. So the idea is to make it uniform, so that all of us have the same consents, the same way we are treating these babies, so that once we exchange our patients, there is no, firstly, it protects us legally, and secondly, it gives us better care for our patients. So this will be up on the website very soon.
Thank you, Anand. I just want to, at this stage, inform you that yesterday only, I had a talk with the ICO CEO and the Secretary General, Eva Kokor, and he wanted us to prepare, a document for the use of the entire world about the retinopathy of prematurity. So seeing all this, I got, reminded about the yesterday's meeting, so I wanted to inform you. So we'll use this input there also and make a good document for this circulation to all over the world. Yes.
Okay. Good morning, and a big thank you to Azad sir, Anand sir, and the IROP Society for trusting me with this responsibility of the newsletter. So how did it start? It was the pandemic time, summer of 2021. There were hardly any physical meetings being held. We were all mainly connected through our WhatsApp group, where we used to share challenging ROP cases, seek mentors' opinions, post any awareness activities done, or even finding ROP specialists in a remote part of the country. One such day, Azad sir suggested to start newsletter of the society, and with such a warm message saying, "You all are my children and assets, go forward and fulfill my wish." With these blessings and unwavering support of Anand sir, we moved forward. So we formed an editorial board which included at that point 7 members from different states who were active on the group. We made a separate WhatsApp group and connected through a Zoom meeting and decided how to go about it. At that point, we had decided no advertising or involvement from any pharma companies. We'll do it on our own. So with delegation and teamwork, here came our first inaugural edition of the newsletter, which was released on the World Prematurity Day, 17th November 2021. The soft copy was emailed to all around 800 VRSI members and the group members, and we received very encouraging feedback. And it actually raised awareness about the presence and strength of the society. The highlight of this issue was the inspirational journey of Dr. Tapas Padi, who's the head of the department at LV Prasad Bhubaneswar, who had just received the prestigious Rangachari Award that year at AIOS for his exceptional work in ROP, which researched the rate of retinal vascular growth as a predictor for treatment-warranted ROP. The newsletter also included ROP basics for the general ophthalmologist in terms of screening guidelines, ICROP classification. There was an excellent photo essay showing the laser for aggressive ROP, how can it be the good, the bad, and the ugly. There was also a case report which emphasized on long-term follow-up of the treated ROP babies to detect any refractive error, strabismus, or amblyopia. It was heartwarming to see one of our members was collaborating with IITians for the innovative idea to address, are we injecting right amount of anti-VEGF in these tiny eyes? And they actually proposed designing a special syringe which can deliver different dosages, especially in the nanoliters. And also we compiled members directory state-wise preliminary in that issue. Our next newsletter was released last year, and which again came up with Professor Azad sir's beautiful poem, which shows his passion for preventing infant blindness. The highlight of this newsletter was the role of laser in an era of anti-VEGF, where our dear mentors, Dogra sir and Subhadra ma'am, shared pearls of wisdom. This interview actually comprehensively covers all areas of ROP lasers, and including the indication for primary laser, technique of the laser, timing of the laser post anti-VEGF, and with their incredibly vast experience, this article actually is much more informative in practical terms than probably a textbook chapter. There was also a case series about non-responders after intravitreal anti-VEGF therapy and the key observation from Dr. Tapas's group. We also did a book review of then recently released ultra-wide-field photography atlas of ROP by Dr. Sushma. We shared glimpses of 8th annual meeting of IROP, which was held at Shankanetralaya and which was a huge success with nearly 275 delegates. It covers advances in basic sciences and ongoing research to all aspects of ROP management as well as medical legal issues. And Anand sir presented the consensus guidelines on anti-VEGF in ROP in Indian settings. Dr. Bhende received Michael Tracy oration at that meeting, and Professor Shunji Kusaka received Dr. Rajwardhan Azad oration, as Anand sir just mentioned. So all in all, it was a great academic feast with lots of national and international ROP experts. Members' Corner proudly occupied the largest space of that newsletter, which showed the stupendous amount of work our members are doing academically, clinically, and even socially. So in the members' achievement section, we subdivided into awards and conference newses. So Dr. Badrinath Oration Award was given to Dr. Dogra sir, and Dr. Bhujang Shetty Oration Award to Dr. Pramod sir. This is the last AIOS news where Kidrop received the best of the best paper poster for their battle against ROP blindness, 15 years of a telemedicine program. And this is our consensus group where the anti-VEGF guidelines were formed. Whenever our work is covered in media, it always reaches a larger population. So our members are working and their work is being appreciated in local and regional newspapers, TVs, and radios. Also, members are coming up with innovative ideas to raise awareness about the ROP. Radhatri Netralaya started lend your voice kind of thing, which means they got on board popular singers, actors, politicians to talk about ROP. Other people have been doing awareness talks, walks, and poster distribution. Training and teaching is the need of the hour with increasing burden of ROP in India. So our mentors and other members, senior members, are doing workshops, seminars, webinars to train fellows, residents, nursing staff. On publication front as well, many of our members are very active. They are publishing their work in index journals, be it a case report or a multi-center collaborative studies. These are the glimpses of our next newsletter, which will be published by end of the month, and the focus would be on the role of biosimilar anti-VEGF for ROP. And also, as we just discussed, the basis ROP, the experience of the first multi-center collaborative study from our IBROP members, which has just been published in Ophthalmology Retina. So what are the advantages of having our own newsletter? It certainly gives a platform to all who deserves to showcase their work. It's a mean of knowledge sharing. It also keeps us motivated and updated. There is a feeling of staying connected. We might not meet all members physically, but it gives us a feeling of connection. And it certainly raises awareness, not just amongst the members, but other ophthalmologists and neonatologists as well. And it promotes society's motto to breach barriers and break boundaries to foster clinical and ethical excellence in ROP. So what next? We are planning to do a regular biannual newsletters. We might consider print version at some point, and we might work on strategies to target larger groups, including more general ophthalmologists, neonatologists, and we can archive all the newsletters on our IROP website. Thank you so much.
Thank you, Dr. Shilpi.
Yeah.
And I think Azad sir wanted a directory, so we are now combining the newsletter with the directory. So along with Dr. Shilpi, Dr. Snehal and Dr. Shweta will be working on it, and I think by the annual meeting in Jaipur, we will have it both online and perhaps in print. The idea being, you know, one of the more common questions asked on our WhatsApp group is, I have this patient who's going to this state, where can I send it to, who can I send it to? So that's one. But more importantly, we think once we have an accredited member in a certain area, we should be able to share this directory with neonatologists. We'll share it with the NNF so that they are also sure whom to send it to. So this will also be an incentive for ROP people to join our society. A decision has to be made on whether we want to have associate members of neonatologists. There have been some neonatologists who want to enter. Since we are a society purely academic and there's no voting and politics involved, we have not created bylaws, so that's something perhaps the mentors will decide and we'll come back on it. Also want to thank a lot of you who have come to this conference only for the IROP meeting. I think that really shows that you all have such great participation in our society. Thank you, Dr. Shilpi.
So Anand, do we know like those who are sort of not accredited or those who are doing ROP work, good work, but they may not be a member. So whenever member directory is there, maybe there is some way that you put that these are members and then they are non-members, because there's so many large number of people.
So
who
I
are
think
doing
our
great
incentive
work.
would be if you
will
are doing ROP
differentiate?
work, you should be a member. We want to reach that. Once we have the directory, we will publish it through VRSI and AIOS. So every ophthalmologist, a retina person, at least through VRSI, who's doing ROP, why shouldn't he be a member of IROP?
Yes, they
and
should
that would be an
become members.
incentive that tomorrow you will be accredited. And I think legally also we will eventually have a strength saying that you're a member of the. Talking about about the legal aspects, a lot of the question in the last few days on our group has been about anti-VEGF and off-label. And I think last year we spoke about it. We are still working with the National Law School, India University in Bangalore. There is a committee created. It's not as simple as we thought, but it's not impossible as well. As we have time and again said, off-label is not illegal. And what the legal specialists have to say, and the best legal minds in the country have to say, is that the fact that AIOS and VRSI leadership managed to withdraw the ban in 2017 after 64 cases of adult endophthalmitis across the country, the fact that they reversed the ban of use of Avastin is an extremely strong point for us to be able to defend ourselves in court. Having said that, we will have to have a peer review publication with the lawyers stating that, and we have precedents from the United Kingdom and in France. The UK, for example, says that first you must give Avastin and then you must try other molecules because the NHS works on a cost. And this we have references for all of it, and the legal committee in NLS is working on it. I'm hopeful, but I can't promise that we will have this paper out by our July session. So
Yeah.
that's
Anand,
one.
I think one thing also we should do, because the VRSI currently the consent form does not include ROP. So we
And
should
does
work
not
with
include
VRSI.
bilateral simultaneous
Yeah,
on the same day as
so
well.
with VRSI we should work so that their consent form includes this based on
Yeah.
all the evidence that we
Yeah.
have, because VRSI should,
Suggest you take up this thing.
yeah,
And
we
talk
can,
to VRSI,
yeah.
get it done.
So we can write a letter from behalf of IROP.
And
that
I
these are
think
the
we should use the
evidences.
advantage that Dr. Partha has, in his inaugural address yesterday, specifically said that his top agenda is pediatric preventable blindness. And he didn't mention ROP, but he certainly spoke about myopia, and I think we can press him to make this a very important agenda.
Subhadra, you take up this issue.
Great.
And
She has the best persuasive powers anyway.
get it done and tell us.
It
Yes,
is now my
yes,
proud
we'll work with
privilege
the
to
videos.
introduce our oration awardee.
Anand, may I ask you, because one big problem we are facing generally in Europe is that we don't have a lot of young ophthalmologists that want to take care about ROP because it's risky, it's very, very difficult to manage. And what's your experience here? Because for us it's a very big problem.
I understand there's a publication from the US which also states that the number of ROP specialists is coming down because the average litigation is about $250,000 to $500,000 US. So I think that fear has not yet gripped us, but very relevant questions get asked. Our problem is a little different. A lot of the retina fellowships in India right now don't provide ROP as part of it, and then they end up learning ROP later, which is fine, which is one of the reasons why we wanted to create a pediatric retina specific ROP training. A lot of our institutes do give ROP training, but it's somehow not all the time integrated into the retina fellowship. With anti-VEGF becoming, I won't say mainstay, but an important consideration. General ophthalmologists can also be trained to do that, so long as they know how to diagnose and follow up and eventually refer for laser when required. So this is work in progress. We don't have yet the fear of, if I do ROP, there's going to be litigation, because perhaps we are a slightly less litigious society than the West. But we are getting prepared for that, because I don't think that day is far. It's now my proud privilege to introduce you. Professor Domenico Lepore has very graciously consented to be our oration awardee. So Professor Lepore is a distinguished professor of ophthalmology at the Catholic University of Sacred Heart in Rome, Italy. After completing his medical studies in Italy, he went on to do ROP research way back in 1995 at the Children's Hospital of Philadelphia under Graham Quinn. And as you know, Quinn has been on all the ICROP classifications since its beginning. And with that, started his lifelong journey in ROP research and care. And he has contributed enormously, not just in research, but in imaging. His angiography, more than a decade back, was the cornerstone of us understanding capillary non-perfusion and how these this disease behaved, both in the normal course and after treatment. His work has combined clinical excellence with research-driven innovations, making him a respected figure, not just in Italy, but internationally. He has been instrumental in establishing screening protocols and refining treatment strategies for ROP, especially with the use of laser therapy and anti-VEGF in complex cases, because of which he has been a key investigator in very key studies, including the Rainbow, which got published in Lancet, the Firefly, and of course, tremendous work on angiography. he has now not stopped with that and has started to do a very large collaboration of artificial intelligence with the Stanford group, and which is going to be his talk. He currently serves as the president of the Italian Ophthalmology Society and is a proud member of the ICROP3 classification, in which he contributed, and I had the privilege to work with him. And he's been a great friend, not just to the Indian ROP Society, but to so many of us, guiding us, and as Sir mentioned, almost single-handedly has managed to get the World ROP Congress happening this year in December in Florence. So again, a very kind invitation. It's just a 1-hour beautiful train ride from Rome. So I think all of us fly into Rome, and then all of us can, and a special package is hopefully going to be worked out, because we are piggybacking on the Floretna meeting. With these words, I'd like to invite and appreciate the fact that you have received the Professor Michael Treacy oration. Before you actually address us, I'd request our president, Dr. Rajvardhan Azad, to give you the award. And if someone can take a photograph, we'll need this for the newsletter. I invite Dr. Narendran on stage as well. He's one of our founder members, and Dr. Parijat as well, and Dr. Sucheta. Please, all of you all come.
Yes, that's a good idea.
Okay, it's not usual to have an award as a ROP specialist, but I think I want to thanks Anand and Dimitri for the invitation. It is a very good pleasure to be here, because part of my career started here years ago with the Indian organized World ROP in Delhi in 2008, and it was a beautiful experience. And part of the work that I done with Graham in the fluorescent angiography started in the afternoon in the lobby of the Le Méridien. So it's a very great privilege. Plus, ROP is a worldwide family. We are not so many, and this is important because we are working together, and everybody is more than happy to help who's approaching this problem with their expertise and sharing cases. And now it's very easy with WhatsApp and any kind of way to share images. We are more than happy to collaborate and to give our expertise to the people that is approaching this very difficult pathology. And in terms of fathers, I think that is not working. Okay, these are my disclosure. As Anand said, I was one of the committee in the member in the Firefly and in the Rainbow study. We accomplished the Rainbow, and now we are finishing almost. We are now analyzing the 5 years data on for the Firefly organized by Bayer. Mike Treacy, for me, has been like a father, because he was the one that really introduced me to the vitreoretinal surgery. As a fellow of Graham Quinn, Graham is a pediatric ophthalmologist. He was, I can tell you because it's not nothing bad, but he was in Centerway competing with Mike, because Mike was more in favor of surgery approach, while Graham was more conservative and tried to fix the point of very good screening and very good methodology to avoid vitreoretinal surgery. But when I approached the vitreoretinal surgery, pediatric vitreoretinal surgery with Mike Treacy, I found out that it was not so difficult, because one of the characteristics of Mike was really to make simple the very difficult things, like approaching the retinal detachment in ROP. I think that one of the things that inspired me was the way he was talking with patients and parents, of course, because he was very, very patient, trying to explain and make people to understand what was going on. And this was very difficult because talking with parents involved in ROP for their kids is very difficult. People don't want to understand in some way. And he was very patient, was spending a lot of time talking with them and make things simple again. And I put this picture on your right because the main reason why Mike was involved in pediatric ophthalmology, besides on this guy, is a legend in US, is a fullback in the team of the Los Angeles Rams, and is the reason that the guy was so good that Mike lost his position in the team at the Michigan State University football team, and he started to be involved in ophthalmology. If Tom Mack was not there, probably we will have a good football player, but not as fantastic and extraordinary surgeon in pediatric ophthalmology. And another thing I always keep in my mind when I see kids, the same I see I said monologue that he does when he did when he was seeing patients. Good, pretty good, good. And this always when I see baby, I always keep in my mind his voice is a fantastic teacher. Just to put together a very long story, he was graduated in the University of Michigan. And he did the OD, the optometry degree before the med school at Georgetown and the residency at Jules Stein Institute in Los Angeles. So he visited almost all the entire United States, and it was a fellow at the National Eye Institute, and in particular, Robert McNamara was his the doctor that approached him to the pediatric retinal diseases, and he held a lot of leader position as a director of the vitreoretinal surgery in the University of Kansas, and finally in '82 he joined the Associated Retinal Consultant in Michigan, and in '82, and since that moment he spent his entire life in the William Beamon Hospital in Detroit. And finally, he also reached an academic position, becoming clinical professor at the biomedical science in the Oakland University and a clinical associate professor at Wayne State University School of Medicine. And he was, of course, the head of the adult and pediatric vitreoretinal surgery at the Beamon Hospital in Detroit. Royal Oak, to be precise. The academic achievements are fantastic. One thing that I think about Mike was always in the right place at the right moment. He was visiting Charlie Chaplin when he was fellow of Robert McNamara, and he was in the right place every time in his life. He received the Donald Gass Award in 2013, and what was the most important award he received was a laureate award of the American Academy in 2001, which is a very rare award that sometimes American Academy give only at a very important member of this society. And in terms of leadership, I like this picture because they were so relaxed. And in Calgary, in Canada, the meeting was organized by Hanels, which was one of his fellow, and it was part of the International Committee of the Second Classification. And among the others, I think that what was inspiring in the last years of Mike was to create a group that is not only taking care of ROP, but also taking care of pediatric retina in general. That's why he pushed Cindy and Amy Hartnett to organize a biannual meeting in US about pediatric retina. And this year there will be in September at Duke University, the APR meeting, Advanced Pediatric Retina meeting. And of course the other idea was to create a society, and probably if we can accomplish this, there will be another another way to honor the memory of Mike. So talking about what he did in his life, pediatric vitreoretinal surgery is his main job. He revolutionized the pediatric retina surgery with introducing the concept of lens sparing vitrectomy. I was visiting many years ago Tatsuo Heroes in Boston, looking at the open sky vitrectomy, and it was quite it scared me, and I decided not to do this in Italy anymore because it was very complicated, and a very important expertise was needed to perform that kind of surgery. What I found when I went to Detroit was that at least it was feasible. Of course, it was a merit of Mike, but because it was not, it's really complicated, but at least less complicated than open sky. And so he did with many others visiting people in his institution. Well, I think someone is here in the audience, and I think we can share with them the same approach, because you can easily understand the people that was trained by him. It can be recognized by the approach that he does, not only with parents but also with the cases that he was dealing with. Another important issue is the classification of the fever, the familial exudative vitreoretinopathy, and the Coats disease. And I think that the techniques that he performed helped us to restore the vision of at least 2,000 children. And then the impact that still Mike has in the pediatric ophthalmology experts is very important, and we have to continue the path that he shows us, because that will be the best way to honor his memory. And again, he was also a translational scientist. He was able to to create some instruments. The spatula that we use during surgery is another important creation by Mike, and he tried also some innovation in the vitreolysis, like the ochreplasmin. But what most important, he started to use genetics in the approach of some of the pediatric vascular diseases, and something that now is becoming very popular because we have a lot of easy instruments to use. It started to apply in that difficult time, studying all the vascular diseases in the pediatric era. But what I want to emphasize more is the work in telemedicine, because it started in 2000, showing us that it was feasible to realize that screening using telemedicine for retinopathy of prematurity. And starting from this paper, Hanels was able to demonstrate that there is a possibility to demonstrate, to have a concept of referral warrant, which means that sending the babies that only need to be treated is important, because you can save money, you can save time, and also you can use less the expertise of pediatric ophthalmologists. I will end time. This is just to be in the timeline of the pediatric telemedicine studies. Started in 2000, and we are still going on. One of part of the study is done here by the Indian group, and the concept of referral warrant is the ability to identify the stage that really need to be treated, and this is time saving, and it's also money saving, because you can save a lot of unuseful examination, and also a lot of money that can be spent because of the transfer of the babies towards a treatment center. Starting from that, Mike started another study that was ROP study, with the possibility of following the baby during the clinical course of the retinopathy of prematurity, and he demonstrated that the screening done with ROP was possible to to have a sensitivity of 92% and specificity of 67%. That means it's very excellent results at the time. Then other studies started. Darius started with the sound ROP, and I was part of the committee. Birgit Lawrence in Germany, Anand in India, Boston, and Mike Chang, of course, started the IROP study that is still ongoing. It was one of the most important studies in the field of the ROP, and the long ROP I did with Mike, and finally also Graham did some study on EROP based on telemedicine. It is one of the most important things about this study. I was part of the committee too. It was that non-physician readers perform much better than experts, because they are completely open mind. If you train them to recognize a lesion, they work very well in their job, and they work better than experts, because sometimes we put our expertise, our thinking in the analysis of the image, and we lose the objectivity of the image. KidROP is Anand's work, and it was fantastic because it was the first and largest world program to employ non-accredited non-physician to grade and report ROP, which is the direct consequence of what Graham said in his study. And this is very important because it shows us that it's important to, it is feasible to do this kind of screening in middle-income countries and with very critical demographics issues. SunDrop is another study. It's a fancy one because it was done in California and with a lot of money employed. But the important is that we need to be in time. We need to be we need to treat the baby in a very efficient way, and telemedicine can do this. And in particular, he compared the use of digital camera to the biome, to the indirect biomicroscopy, which is still the gold standard. When we started to work on ICROP, and Anand remember this discussion, we took the idea that we have to refer to binocular indirect, which is still the most important, most common instruments to screen the ROP, while we have to affirm that the telemedicine and digital imaging is unrivaled compared to the biome. And that's what Darius was able to show in this study, SunROP and LongROP, which is the long-term follow-up in these babies. Because why telemedicine is better than bio? Well, if you look at images, the right you see the bio images compared to the draw that usually Darius does when he's screening in his NICU, compared to the images that you can see the evolution of the disease very well, and this helps you to be exactly on time when you decide to treat the baby. And also, of course, you can realize a composite and any kind of analysis you want to perform on these images. It is feasible. Even teach our students how to treat the babies. It's much more easy when you use this instrument. What you need for telemedicine? We need a digital fundus camera. Hopefully, we'll have a less expensive camera and easy to use in the NICU. We need trained personnel, we need internet access, we need experienced ophthalmologists, and also we need image management software, which was at the time quite difficult to find, but right now with the artificial intelligence we will see we have instruments that are very powerful. This is a workflow and how to organize a telemedicine screening in ROP, and this is the system that is now in place in California. You have to set a very strict protocol. You need identification of the babies in the NICU, notification to the MD that will take care of the baby as soon as they are discharged from the NICU, the standard photographs and report generating, and recommendation to repeat the screening as soon as they are discharged. You need to set a mandatory multiple examination schedule, which is part of the entire the work that we are done when we set the new guidelines. A little dilatation is needed to allow to have a good photos, and then to set a protocol of the image. So you need an external optic center, superior, inferior, nasal, and temporal. And finally, the American Academy of Pediatrics, together the American Academy of Ophthalmology, defined that the use of electronic information and communication technologies provides support healthcare when distance separated participant. It is very well accepted for ROP screening in the US. There are also companies that together with insurance company in US start this safety network focus to create an educational platform in certification for telemedicine screening. And in terms of biomarkers, we will discuss this tomorrow in the other session on ROP. It is important because telemedicine is part of the ophthalmological features that is a direct biomarker of the ROP. And but what is more important is that we need a new algorithm that can help us to manage ROP in terms of enhanced image analysis. Fluorescein angiogram can be realized in different way. Angio-OCT is an example, but artificial intelligence can help us to get the same information from a regular fundus image. The weight gain-based risk prediction model is another important part of the new algorithm that we have to create to manage the ROP in a better way, and quantification of vascular tortuosity in order to avoid the inter-observer variability that we face every day when we look at an image of plus disease. And with this kind of background, the requiring treatment, the efficacy of the treatment will be 99%. So this will be, this is bad news for the vitreoretinal surgeon, because we show that it is feasible to have zero retinal detachment in a controlled way. If you look at the rainbow results in the perfect world of randomized and controlled study, no one got a retinal detachment. And this is very important. If you do the right things, we can avoid the blindness from ROP. And again, he was already facing the battle against the pancreatic cancer, and he wrote this paper, The Renaissance of the Theory of Ophthalmology through the Artificial Intelligence, because he was a real visionary. He was able to understand what was going on and what will be the future of the pathology he was always fighting. And the artificial intelligence is the new instruments that together combined to telemedicine will help us to reach the 100% avoiding the retinal detachment. And so I can conclude this. The future is here, and if we keep the path that Mike traced for us, we'll have a very bright future for our kids. Thank you.
Thank you so much, Professor Lapore. It's indeed an honor for us, for you to give you this oration, and thank you for giving us sort of deep insight on our common mentor, Mike Tracy, and leading the way, and then sharing your experience and telling us where we are poised now for the future of ROP. Thank you once again.
Thank you very much for your wonderful presentation, and I would like you to share us the PPT of your presentation so that we can get more out of it, and we'll discuss in our council meeting about various things you have said, how we can also develop such things, few things which is very attractive and which is very interesting for us. So I hope there is no copyright.
No.
Maybe some copyright may be there, but
there will be no copyrights, unless I have to tell you that I mean, the story with artificial intelligence, everybody knows there is some commercial interest, even in getting the FDA approval for the system. And what I want to emphasize that the work we are doing with AIOS is completely will be completely free, and as soon as we get the authorization, they will be available for everybody without any charge. I think this is important because we need to use these instruments, and we need to be the key. We need to be the key of the use of the artificial intelligence. We don't have to have been submitted from the companies that included artificial intelligence in their system. We are the doctors, we are the leading, we are the stakeholders, and we have to analyze the data. We are not only the validator, we are the doctors, and this is very important.
Thank you. We have two presentations and 15 minutes, so we'll hurry up on that. Shweta Mangalesh, you've seen her work. You're probably seeing her for the first time. She's been in the ROP program for over a decade now. Started off as our student, and now has worked extensively in Duke University, and now set to do her public health studies in the United States, but she's working behind the scene. In fact, the website of the IROP has been created by her. She's also big into creating all the digital platforms. She'll share with us what we've been doing for training and certification, which, as Sir said, we will take it forward as a society. Shweta, on to you.
Thank you so much. So I'm the founder and director of a tech-based startup called Child. And what we do is we use innovative technology and AI to develop training and certification, mainly for ROP and child eye health programs. And our goal is to work with IROP to create an accreditation training and certification program for ROP. So what is our vision? We want to standardize training. I think as discussions went on today, there is no consistent training in the VR fellowship currently in India for ROP. We want to make it accessible to all healthcare providers involved in ROP care, establish recognized credentials from the IROP Society to ensure quality, but also reduce medico-legal risks. And finally, leverage newer technology, including AI, telemedicine, and other mobile platforms to extend training to underserved areas. What is the need in India? And as I mentioned, the gap between what is available and what is the need right now is quite high. And despite the presence of guidelines in India, we don't have a consistent program that is being run all through the country. And through this training platform, we want to sort of make ROP screening and treatment consistent all over India. Key challenges include, and what we want to mitigate with this training platform is a lack of centralized training, uneven distribution of trained specialists, so a lot of geographical areas not being serviced by our trained specialists, and a number of medico-legal concerns. And as a society, I think through the training platform, we can work to address the increasing number of litigations that occur with ROP care. So what is our solution for this? One is a unified mobile app, because everyone uses cell phones these days. It's available all across. So a mobile app for training and certification. AI integration to make multilingual content to get more people trained and involved, and also generate case-based simulations. Remote diagnosis and mentorship with the experts in the IROP Society. And also medico-legal compliance. So make sure our training is robust and recognized and legally relevant. This is a demo of the app, or what the app will look like. We're still developing it. There's advanced security, automated image review using AI. So all of the training will be ratified by this AI model. And there's online mentorship built into the app as well. So you're going to get one-on-one mentorship. So basically, we want to make it as easy, as accessible, as uncomplicated as possible. Some of the features, as you've already seen, is AI image detection. So we are going to leverage large data sets from, for example, KidROP, to identify accurate images, generative AI translations for multilingual training, especially for technicians, a secure cloud platform to host all of the data, and eventually turn it into an interactive learning platform which supports both VR and AR simulations. Our targeted audience is not just ophthalmologists, but everyone in the ROP ecosystem, which includes non-physician technicians, nurses, neonatologists, as well as ophthalmologists. And the app will have role-specific training tracks. So separate training track for ophthalmologists, a separate training track for neonatologists, and one for technicians and imagers. And the training would be specialized for each role. The other important thing that we wish to include, or we are working to include, is the medical legal and documentation modules. So again, with the number of litigations, some of the key precedents that we're going to include is a detailed discussion of the lawsuits and misdiagnosis of ROP, especially for ophthalmologists and neonatologists. Mandatory consents and records, and this would be standardized from IROP society, and what the society deems is the standard template, and that would be made available, and the clinicians would be trained on this. Other risk management for legal, to mitigate legal issues, which include counseling, consent, making sure all of your legal documentation is accurate. The certification process then would involve assessments within the app, some practical proficiency, a certification award via IROP society, as well as recertification, as and when guidelines are being updated, there's new development. So it is an all-encompassing app that will include most of these. So what is our implementation plan? We're currently working on app development. We're going to then reach out to different pilot sites to test out the app, make sure the AI is working okay, roll out in different hospitals. The official rollout would then start off with tier 2 to tier 3 cities, and then finally we would work on a nationwide launch with full certification. Some of our collaborations for this would include government support of medical device industry, the telemedicine cameras, which are 4S and RedCam, to make sure our app is compliant with them, and legal partners to get advice on medical legal modules. The impact is not just training and certification of one single individual or trainees. It is to make sure there's enhanced access, so we're breaking geographical barriers to bring training to all. Also, we're mitigating we're preventing blindness, we're saving blind person years, and we want this to be a globally recognized model where the certification and accreditation program by IROP Society can be then globally used in other countries as well. Thank you.
Thank you, Shweta. As you can see, we have exciting times ahead. We're integrating technology on your phones and all the things that we wanted to do. This will be linked to the store where you can purchase. It will be linked to our website, the directory, and everything will be online. We're just looking for a little funding. It's not too much of money, and I'm very, very confident of getting it as well. Come to our final speaker. We have shorter than expected time, sir, if you could wind up soon. So sir is going to talk about our last agenda that we spoke about, that is working with the government and how we can engage them. Pramod Bindi.
Yeah. This is the previous one. We need day 2. Number day 2. No, it's day 3 is coming. Day 2 चाहिए. Yeah, yeah. Uploaded, check.
Hale.
No,
Huh?
day 2 चाहिए मैंने. You are showing the day 3.
Day 3.
No, that's what I'm telling you. That's what right.
Okay, so while sir puts it up, once again, thank you all of you, and we have members from APAO, our neighboring countries as well. And once again, thank you to Professor Domenico.
Day 2 चाहिए.
And we are going to look forward to seeing you in July for the annual meeting, and hopefully very soon we'll put up on the website for the World ROP Congress as well. Oh. So what you can do is, without the presentation, tell it's there. If any of you all have not submitted your achievements, please do so through either Shilpi or Dr. Karobi, since Dr. Karobi is not here right now, but she's in the meeting, and you know she's the ambassador chief, so she takes care of all our achievements, because by July we should have it updated. देना पड़ेगा वाला.
So basically, when you look at the childhood blindness, you have prevalence is somewhere around 6.5%, and it's vary widely from region to region. Reasons being socioeconomic development, availability of primary health care, and availability of eye care services. And probably ROP is the second common causes what we have, and that's why we all are here. So can you move forward? Yeah. So under National Health Mission and under with this universal high screening, basically below 18 years of age, with early detection and treatment for what they call as almost 30 selected health condition, 4 Ds they are given. I will not going to go detail about that basically. So, and for us, when you talk about universal eye screening, basically primary target age group is early neonates, and probably first screening should be done preferably within 42 to 70 years of delivery. This is overall eye health when they are looking at it, and aim to identify the eye disorders right at the birth or during the stay in NICU, so that you can utilize that time to prevent or treat at the earliest for a better final outcome. And also it is important because critical period of brain development is first 2 years, and when you have that cognitive development disorder, what you see during this period, suppose vision is not developed, all these factors get affected as well. Now, what are those newborns at risk for vision impairment? When you look at it, our premature infants comes right on the top. When you have other family history with other ocular disorders, and infants with associated cognitive disorders and neurodevelopment delays also need to be screened for a thorough examination. And when you look at 3 typical examination criteria they are given, let's look at the eye history, significant ocular history, external examination of the eye, and the red reflex. And depending on that, if you have a family history of other congenital disorders, ocular disorders, probably yes, ophthalmologist should be involved in screening of the baby. If you have associated eye problem or some issues with the red reflex, abnormal reflex, and these are the babies need to be screened by ophthalmologists. But other first level, it can be done at the level of neonatologists or NICU nurses. So ROP, we are not going to go much detail. We all of us know here, all our ROP experts are sitting here. And what is universal screening? Basically for ROP, look at it, is to ensure all at-risk preterms undergo systemic eye examination to detect early ROP which allows time interval to prevent blindness or severe visual loss. And these guidelines probably all of us know. I'll skip this guideline. Clinical protocol, we all know how to screen. And basically, so what you look at is the benefits of universal screening is basically when your early detection lead to timely treatment, helps to prevent blindness, improve long-term visual outcome in preterm points, and helps track trends in ROP prevalence. That is what is more important for us to better healthcare policy managements. So we have a barriers for this screening. Basically, problem Anand and Dr. Azad always keep on talking about shortage of trained ophthalmologists, limited access to retinal imaging in remote, low-resource settings, high-cost equipment, and poor follow-up rate once these babies are discharged from the neonatal ICUs. So what are possible solutions we have here is that SNC or NICUs to improve access by working with the local ophthalmic community and hospital administrations. First screening can be done using wide field cameras. Images can be taken by technician and can be reviewed by experts. What you talk about telemedicine, we are coming to that. I think future is that. Implementing AI-based screening program, increase awareness among parents, and that is what is most important issue here. Because if parents are aware, if they ask for screening, probably we will be much better off. And if treatment needed, obviously these babies can be sent to regional centers, or an ophthalmologist can visit these NICUs to treat these babies. So indirect ophthalmoscopy obviously is a gold standard, but using wide field digital camera has its advantages because it is technician based. Images can be stored, transmitted for expert opinion, reviewed, analyzed, and sequential comparison can be done. And also it can be, so now new cameras are coming with a small pupil, so dilatation part, risk of those toxicity also can be minimized. RedCam, yes, is a gold standard. However, it has its own issues. Cost is huge. So we have now a lot of handheld wide field cameras, and even smartphone-based screening protocols are coming up. And we are having a new technician-based screening models, or mobile screening units can be, and cloud-based platform for remote consultation are also being tried. And best example what we have is KID ROP is the model. What is important is keeping up those follow-up records. Though each institute has their own format, it is important to document these findings and management decision at each visit. The data for next screening, if needed, must be documented in the medical record, discharge summary, and must be communicated to the parents verbally and in writing, because that will be issue of medical legal issues. And it's good to have a automated reminder system for the parents. So to implement this this universal eye screening, so universal vision screening should be done at all delivery points through doctors, that is neonatologists will be there, obstetricians will be there, A&M staff and nurses. State and union territories should establish at least one state level apex unit for ROP, which should function as also as a training unit. This unit to be located at SNCUs or NICUs of government institute with facility for indirect ophthalmoscopy and dedicated laser, and also possibly should have wide field imaging system. Both screening and treatment should be done at SNCU, and at least 2 beds to be reserved to the ROP procedures and dedicated radiate warmers to be earmarked for the same. At least 1 doctor and 1 nurse for NICU be assigned and trained for screening and the treatment, and identify ophthalmologists in government or private sector who could visit NICU or at least once a week and should be paid accordingly. Help from collaborative centers if necessary to be sought, and ROP screening in National Health Insurance Program to cover this treatment cost is equally important. When you look at mapping services, you need to have accountability also. So you need to assess the workload to prioritize the implementation of screening programs. We'll look at the government database, availability of ophthalmologists in regional institutes, medical colleges and district hospital and private sectors, their competence, willingness, and to get trained for screening and treatment. And that is what is important because compensation has to be there. Availability for necessary equipments, we look at it. And location and equipment really doesn't cost. Indirect ophthalmoscopy, lens and dilatation drops probably should not an issue. Look at district early intervention centers where training staff level for equipment and eye care as per RBSK guidelines should be there. SNCUs with adequate load to be upgraded as a nodal center for teaching and training and can collaborate with RIOs and other medical colleges as well. When you look at the quality improvement, and that is what comes again, probably what she has last presentation will help us. Training for a personnel to deliver best practices, written protocol for screening, treatment, follow-up, and record keeping that gives a uniform way of recording as well as screening, and that will help us future analysis and studies if you plan. ROP screening should be completed prior to discharge, that is the first examination preferably. And if patient has discharged, prior fixed-up screening appointment must be made with nearby screening centers. And it should be documented in discharge report, and parents must be counseled for that. And we try to establish probably national registration. And to validate this, of course, you need a certain parameters, so you need to audit this. So competence of screening program, that's last one, yeah, thank you. So completeness of screening program, which includes percentage of eligible babies who received at least one eye examination. Look at the timing of the first screening. So percentage of eligible babies receiving first ROP screening examination by 4th week of postnatal age, and percentage of babies needing ROP treatment are treated within 48 hours of making decision. If you audit this, probably again you will help to maintain the quality. These are our responsibilities. I am not going through in details. This is all we know on RBS guidelines. Also health communication, what I mean is basically awareness, public education, awareness of healthcare workers using posters, booklets. For parents, sometimes have like what Anand just was showing, our posters, banners, audio visual shows, and if you have ambassadors to help this create more awareness. The word about just artificial intelligence, and that is what is going to come up now. We need to have AI-driven algorithm, a promising tool for automated ROP detection, and also will help to analyze retina images. The basic advantages are it will be automatic diagnosis, increase accessibility, improve accuracy and consistency. What protocols we have, somewhere around 90 to 93% sensitivity. It obviously helps up speed of decision making, but also help us to take challenges like limited specialty availables, high patient load, delayed dissection. That is what it is going to take care of. But however, it has its own limitations because variability in image quality, how the way input will be, that is important. You need a regulatory approval for that, for government organization, ethical and legal concerns, and it has still limited generalizability, which probably have to work on it. So I think that's why I'll conclude with it. Thank you very much.
Thank you, sir. Thank you, sir. We've already overshot, so we'll be handing it over to the next session.
Sorry. Thank you much. Thank you.